Hi, my name is Ross Camidge. I'm the Director of Thoracic Oncology at the University of Colorado. And today we're going to talk about ALK, both the past, present, and future of treating this molecular subtype of disease. So I'm joined today by two very special guests. Jessica, would you like to introduce yourself?
Sure. Hi, everyone. I'm Jess Lin. I'm a thoracic medical oncologist at the Massachusetts General Hospital Cancer Center. And my main areas of focus are fusion-driven non-small cell lung cancer, such as ALK-rearranged lung cancer.
Great. And then our very special guest, Linnea, would you like to introduce yourself?
Sure. My name is Linnea Olsen, and I was diagnosed with non-small cell lung cancer back in 2005. Found out I was ALK-positive in 2008, and I'm fortunate enough to have Jess as my oncologist.
Great. I mean, I think Linnea's story really illustrates how this field has changed. I remember, I started in thoracic oncology about the same year that you were diagnosed, Linnea, back in 2005. And I remember, young lung cancer patients coming through who'd never smoked and they didn't have an EGFR mutation. You had to look for that. And they would do incredibly badly. And, people were sort of like, why doesn't the EGFR inhibitor work? And that's because clearly there were other things driving their cancer. And I often wonder if we had the testing, would they have turned out to be ALK? So you've been, oh my goodness, I can't even do the math in my head. What's that, 15 years with a diagnosis of advanced lung cancer. And Jess, you were telling me you've been a fellow for maybe the last, a fellow for like 3 years, and then you've been faculty for 2 years. So your entire history is about 5 years. So Linnea probably beats both of us in terms of her experience with lung cancer.
That's right.
So let's talk a little bit about the history of ALK and what got us to maybe the last 5 years. I mean, we started to figure out how to identify these things in the late 2000s, and it was fortunate that there was a drug already in clinical trials, crizotinib. Did you go on that initial phase 1 study, Linnea?
Yes, actually, I ended up being the 4th person in the world with non-small cell lung cancer to go on that trial.
And how did it work for you? Did you notice a difference as soon as you went on it?
Within days. And you have to understand that I was truly preparing to die before this, because I belonged to that cohort you were describing, young, never smoking patients who weren't EGFR positive. So this was a complete surprise to me. But yes, I began to feel better within days.
Wow. How long did the crizotinib last for initially before you had to do something different?
Well, I had progression after a year, which was pretty typical. But of course, there were no other ALK inhibitors.
Yeah.
So I was able to stay on it for another 2 years until crizotinib came to trial.
And so you just stayed on with progression, or were they doing other things at the time?
No, I stayed on with progression.
It's funny because I remember this seems kind of crazy in retrospect, but the whole idea about treatment beyond progression was like crazy town. And Pfizer, this very small group in Pfizer, were just wonderful about allowing us to think outside the box to allow us to do that. And they even allowed us to add in radiation and other things for some patients. So then, Jess, looking from the outside, how much of that, I guess it was already, a lot of that history was already written by the time you got into thoracic oncology, but what was your impression of ALK when you started as a fellow?
Oh, I found it very fascinating and inspiring. I knew that at the time that ALK was discovered, it was really only EGFR that was felt to be an actionable oncogene driver in non-small cell lung cancer. And the main question was, well, could such success with targeted therapies also be applicable to other patients with non-small cell lung cancer? And the fact that there was ALK and that there were patients with ALK-rearranged lung cancer that could be successfully treated with ALK inhibitors, I think then fueled further efforts to identify other biomarkers that could be treated with TKIs. And so seeing how rapidly the targeted therapies were developed for patients with ALK-rearranged lung cancer, and the fact that there was such a marriage between translational and clinical research efforts that drove that pace of discovery. That was very inspiring for me.
Yeah, I mean, it really was. I mean, it's funny because I remember when EGFR first came out, it was viewed as this exception. You know, there was EGFR, and then don't worry about the rest; it's too complex. And so I actually think the second example, ALK, was what changed people's minds.
Mm-hmm.
If you have two examples, then where's the third and where's the fourth? So, you know, it really, you know, at about the same time when ALK was being discovered, that was also the beginning of something called the Lung Cancer Mutation Consortium. And it wasn't that the scientific discoveries of, you know, it was actually one of the stimulus grants under Obama, you know, if you remember that first economic crash. And the goal was to get every major cancer center doing routine molecular testing, which they weren't doing. And it was the ALK part of the story that helped sort of leverage that. So, you know, again, proof positive that ALK really changed the field. So, Linnea, back to you. So, okay, so you're busy preparing to die. They put you on a pill. You know, you have amazing. I mean, Alice Shaw is your oncologist, so an amazing team looking after you from the get-go. When did you decide you wanted to be an advocate? And maybe explain what an advocate is.
Sure. Actually, back then, Tom Lynch was still my oncologist.
Wow.
So it would be when he left for Yale that I inherited Alice.
Okay.
And I had talked to Tom about wanting to do something, but the whole idea of being a lung cancer advocate was still kind of nascent back then. And there just wasn't a whole lot going on. So the first couple of things that happened is I had an opportunity for the first grant cycle of the Department of Defense to be a peer reviewer. So I did that. And then Tom knew that I was interested in writing, and he suggested I start a blog.
Wow.
So, yeah. And, you know, now the blog has been going for, gosh, it's 12 years. So
that's incredible. And what's the title of your blog?
It's Outliving Lung Cancer.
I love it.
Thank you.
We talked about how ALK changed the medical side, but I think it really changed the advocacy side too. You know, again, you know, we had EGFR patients doing well, but suddenly we did get subgroups of patients who could stand up and be counted. And I think that shouldn't be underestimated in terms of its impact just on the whole awareness about lung cancer. You know, you were the tide that lifted all of the boats.
No, I would agree. And I think that part of it had to do, of course, with our initial success, because there hadn't been a whole lot of good news in lung cancer for a long time. So this was exciting for everyone. But I think it also had to do with the fact that so many ALK patients are younger.
Yeah.
And it was just a very different group, and a group that was energetic and not complacent, a group that had and has a lot of young children, you know, so they had so many reasons to push on this envelope.
How did you feel about being essentially a test pilot? Because most of the things that you did, you were one of the first few people to do it. You know, it's kind of like, hey, Linnea, would you like to be a pioneer again? I mean, is it scary?
Fortunately, I'm not risk averse. And it's interesting because this was a quality that in my youth was not a positive. But, you know, I kind of view my job as saying yes and staying alive. And the day that Tom Lynch presented me with the opportunity for the crizotinib trial, I didn't hesitate. I mean, I said yes right there that day in the office. But I also have to add that I knew I was going to die.
Yeah.
And I was so hopeful that this drug would extend my life for a few months.
Jessica, is it intimidating looking after a patient like Linnea, who's been there, done that?
I find it a privilege. I've told Linnea this, and I think of lung cancer treatment both as an oncologist and as a patient. I think it's a journey that you take together, the patient and the doctor. And I think we learn together as we try these novel therapies, especially the ones that are just beginning to be in a clinical trial, learning about side effects, how they affect your day-to-day life, how well they control the cancer. So I find it a privilege to work with someone as strong and as brave as Linnea. And every visit with her is rich with lessons that I learn. And yeah, that's how I think of it.
From a medical perspective, what can you describe that Linnea has helped change the world from? I mean, sometimes she's just contributing as just one patient in a trial, but what's she been through, you know, for those who are cognoscenti of the treatment for ALK? Can you sort of list some of her treatments?
I think in terms of what she's contributing to the community in general, just speaking up about her experiences and the successes and the shortcomings, both the advances that we've made so far and the challenges that we still face every day as we treat our patients with ALK-positive lung cancer. I find it quite striking how many patients come into clinic telling us about the blog that they read or the patient advocacy group that they found, and how important that was to them to hear about the others' experiences, the personal experiences that they would not be able to get just from random internet search or even digging into the literature that's published. I know firsthand how many of our patients are benefiting from patients like Linnea who are speaking up about her experiences.
Okay, so Linnea, you said you went from crizotinib and then you went on Cerridine. How many different lines of treatment do you think you've been on since you were diagnosed ALK positive?
Well, I'm currently in my 6th phase 1 clinical trial.
Wow.
And I've had surgery. I've returned to chemo on 2 different occasions that were within a trial. I also was on Tarceva because Tom had tested me for EGFR initially, and I was negative, but he told me later that because I had no other options, he was just hoping that maybe the test had been wrong.
Yeah.
So I tried that too.
Yeah. And you're currently on a clinical trial that I think Jess is the leader of, is that right?
The principal investigator is actually my colleague, Dr. Dagogo Jack at Mass General.
Okay.
It is an investigator-initiated trial that is run out of the Mass General Cancer Center. And there are several cohorts in the study. The one that Linnea is on is a combination of lorlatinib together with binimetinib, which is a MEK inhibitor. And that combination was built in because there are preclinical data to support that combined MEK and ALK blockade can overcome resistance to ALK inhibitors and could also potentially delay resistance from emerging in treatment-naive tumor cells as well.
Okay. And Linnea, how long have you been on this trial?
I've been on this trial now, I might have to ask Jess, I think about 5 weeks.
Okay, so still pretty new.
Yes, but I've had a scan, and you have to excuse me, I have to plug in my computer. Just a moment.
That's okay. Jess, do you want to carry on? She's had a scan.
So Linnea's been on this trial for almost 3 months now, actually, Linnea.
Really?
Yeah. So
the time flies when you're having fun, right?
Yeah, time flies. Scans were done after about 2 months on this trial, right, Linnea?
Yeah.
And do you want to share a little bit about what your experience was finding out about the scan result? And
yeah, well, I generally can predict pretty well how my scans are going to turn out. But this time I was delighted to be wrong because I really did not think I was improving. And I think it's because I just still have some congestion, which is secondary more to the histology of my cancer. But I actually have had a 57% response, which is phenomenal.
That's fantastic.
Yeah.
And before that, you were on lorlatinib on its own for a long time. When did you start the lorlatinib?
Boy, I started that in, I guess it was May of 2014.
Okay. And Jess, was that because Linnea had the G1202R mutation, or it was just, we didn't know that at the time?
We did. So Linnea had a rebiopsy after progression on ceritinib, and the sequencing did show the G1202R mutation.
Okay. One of the things with lorlatinib is it's one of the few drugs that you can actually, the physician can tell which drug the patient is on just by speaking to them over the phone. But you reduced the dose of the lorlatinib, and that seemed to improve things. Is that right?
Yeah, I entered the lorlatinib trial in the 3rd cohort. And just because of the way my body metabolizes the drug, I was the first to report any side effects. And all the side effects I was reporting were bizarre.
Like what?
Well, like the slowed speech, but also mood changes.
Okay.
Where I suddenly became very emotional and very vivid dreams that were almost like tripping.
Wow.
And then when we finally had to dose reduce, I woke up one morning and it was like my hands were blocks of wood. I had arthritic neuropathy.
Ooh.
So we reduced dose, and it took care of most of the side effects. Some of the cognitive ones persisted. I did feel like I had some loss of memory with lorlatinib as well, where I just couldn't quite organize my thoughts as well.
And that's still there, the 50 milligrams that you're on?
It is, but what is very exciting is that the year that I was off of it, I feel like I returned pretty much to normal. Perhaps the only thing that didn't go away was some of the peripheral neuropathy.
Yeah, so it sounds like it's completely reversible. I mean, my experience, I remember one very florid example of a very nice lady who had delusions and had to be admitted to a psychiatric hospital. And they stopped the drug, and 5 days later she walked out and she was completely fine. So it's not a permanent damage, which is wonderful.
But at first, it's so frightening because it's not what you expect. But of course, it's small molecule that was designed to cross the blood-brain barrier. So.
And it clearly does that very well.
Clearly does. Clearly does.
So Jess, when you start someone on lorlatinib, what dose do you start them on?
So the standard dose is 100 milligrams once a day, but precisely because of these side effects that we know can happen with regards to mood and cognition, for somebody who, for example, has known baseline anxiety that's been bothersome, or has high concerns about impairment with multitasking or concentration, if they're very concerned, I do have a low threshold of reducing the dose to 75.
So you start at 100 and then go down.
So in somebody who has significant psychiatric history, I will go ahead and start at 75 milligram dosing.
Okay. Yeah, I actually start at 50 and then sort of bootstrap my way up. So I guess there's more than one way to skin a cat. Linnea, did you have any of the cholesterol or triglyceride issues?
Oh, for sure. Yeah, my cholesterol got very high and stayed high. And actually that just might correct me here, but I don't think that went down significantly last year either. I think it went down to some degree, but I think that has continued to be an issue for me. But I found that if I stayed really active and avoided most carbohydrates, that I could control not so much the cholesterol, but a lot of people gain weight too, or they have trouble with edema in their lower legs.
So, I mean, I think you've been very, upfront about this is a drug that's kept you alive. Let's not forget that.
Yes.
But it comes at some cost. And, this allows us to kind of move into the discussion about, well, many of these drugs which have been licensed after crizotinib or after some of these other drugs are now showing a lot of activity when you go on them first. And that raises the interesting question of saying, well, is just controlling the cancer the only thing we need to care about, or do we have to pay attention to some of these side effects? So of all of the treatments you've been through, and you've been through crizotinib and ceritinib and some trials and then the lorlatinib, would you have started on the lorlatinib?
Yes.
Okay.
But for me, it's very, very clear that my goal is survival.
Okay.
So I'm willing to tolerate a lot of side effects as long as I feel like the drug is working. The only times it's been difficult for me is when I have the side effects but no positive impact. That's harder to justify.
Okay. And Jess, do you want to talk about, your thoughts in terms of what patients should start on now? If an ALK-positive patient, the next Linnea walks through the door next week, what are you gonna tell them to start on?
Yeah, so I guess we can take a couple steps back and just generally review the data that we have so far. So first, starting out with the second generation ALK inhibitors that were compared to crizotinib, we have alectinib, which was evaluated in the global ALEX trial. We have brigatinib from the ALTA-1L trial, and then the encertinib, which was evaluated in the EXALT-3 trial, and that data was just presented. So brigatinib and alectinib are FDA approved for the first-line indication, and encertinib remains investigational. And across the board, the hazard ratio in terms of PFS for these three drugs ranged around 0.5, and the median progression-free survival for all three drugs ranged around 24 to 26 months by blinded independent review. And then the data from the CROWN trial arrived, right, where lorlatinib was compared in the first-line setting to crizotinib. And this was interim analysis result. And from that presentation, we saw the hazard ratio for PFS was 0.28. Yeah. And there was also, for time to CNS progression, the hazard ratio was 0.07, which is a very remarkable result. And so from an efficacy standpoint, this is the most positive data that we've seen, right? The overall survival data is still immature. But of course, we have to balance that against adverse event profiles. And Linnea highlighted some of the side effects that we can see with lorlatinib. The side effects like hypercholesterolemia, hypertriglyceridemia, and particularly the mood and the cognitive side effects tend to be unique to lorlatinib. We haven't really seen that with other ALK inhibitors. I think with the exceptional CNS efficacy of lorlatinib, knowing that brigatinib and alectinib are also CNS active, for patients with known baseline brain metastasis, I would definitely favor lorlatinib as first-line therapy, understanding that patients have to be aware of different side effects that they may experience, right? And we have to take into account their prior medical history, things like psychiatric history, which I mentioned before. For patients without prior brain metastasis, it's interesting. If you look at the subgroup analysis from the CROWN trial, the hazard ratio for PFS, even among patients without brain metastasis, was actually quite strong. And I think it was better than what we saw with brigatinib or alectinib. So even for patients without baseline brain metastasis, I would be tempted to try lorlatinib after a discussion about potential side effects as well.
Yeah, it's funny because if you actually look at the subgroups, if you look at those who do have baseline brain metastases, lorlatinib actually doesn't look that different than brigatinib. I mean, the hazard ratios overlap. So it's actually the group without brain metastases where, more surprisingly, lorlatinib is perhaps having a greater CNS protective effect. Mm-hmm. It's funny because in the world of cancer, Linnea said when she was diagnosed, you were expecting to die. And one of the questions in ALK is actually, have we moved beyond the idea that PFS, progression-free survival, is a relevant surrogate for overall survival when people are now living for 15 plus years? So, the question, we're making decisions based on progression-free survival because that was very close to how long you lived. But now it's quite possible that somebody's overall survival might be massively exceed their time on their first treatment. So it certainly made me think about, is it just a straight, lorlatinib has the best first-line efficacy, which I agree it does, and whether you can just play catch-up later. So I have to be honest, I still start people on alectinib, and then I keep the lorlatinib in reserve. And I don't know if it's the right thing or not, but that's what I do. Let's talk a little bit about what we don't know. So we've gone through the history, we've gone through the present. What's the future for ALK? Jess, why don't you jump in on this, and then Linnea, you can talk through things from a patient perspective and maybe even an advocate perspective. So Jess, what are the horizons for ALK?
I think since we were just discussing lorlatinib, one of the immediate challenges is figuring out how to overcome resistance to lorlatinib. Okay. Most of our patients at one point or another will see lorlatinib in the sequence of their treatments. And so far after lorlatinib, effective options remain limited, right? So about a quarter of patients who have disease progression after lorlatinib have these compound ALK mutations, which can be refractory to all of the available ALK inhibitors. And so we need newer ALK inhibitors that could potentially overcome these compound mutations. And then the majority of tumors that are lorlatinib resistant are presumed to be ALK independent. And there, for some patients, we may be able to use combinatorial regimens in a clinical trial. But for many others, we have yet to understand and dissect the mechanisms there. So there is still a lot of work to be done in that regard. I think we also have to move beyond the question of just sequencing ALK inhibitors, which, that it remains an important question, but I would like to see us begin to ask, how can we deepen the response and lengthen the duration of response so that we don't constantly have to think about what's the next line of therapy for the patient. And there, one of the concepts that's worth looking at is, well, can we integrate modalities of systemic therapy that are beyond TKIs, right? So in EGFR mutant lung cancer, we saw the data for gefitinib, either alone or in combination with chemotherapy in patients that are newly diagnosed. And there was a clear benefit there with the addition of chemotherapy. And now there's the ongoing trial looking at osimertinib plus chemotherapy versus osimertinib alone. Can we assess that similar question in ALK-positive lung cancer where something, whether chemotherapy or another agent, can be added to an ALK inhibitor from the get-go so that patients can have even longer responses to a regimen? Another major challenge that we're going to have to overcome is making immunotherapy an option for patients with ALK-positive lung cancer.
And when you say immunotherapy, do you mean PD-1 and PD-L1 inhibitors?
PD-1, PD-L1 inhibitors alone, I think we have good enough data to know that by themselves, they're unlikely to be of benefit to ALK-positive lung cancer patients. The question is, can we combine them with different agents, or can we look beyond simple checkpoint inhibitors to other novel immune-based strategies to extend the survival of ALK-positive lung cancer patients?
Yeah, I mean, I think just to sort of flesh some of those out, certainly in terms of those other modalities, the idea of consolidation radiotherapy for those people, take somebody to the point of maximal response and you don't let those areas manifest resistance later, you zap them with radiotherapy. Just as we talked about the tolerability of agents, adding something else in from the beginning, there's a difference between you're on it forever versus you're on it for a course. We have to bear those in mind. I do like the idea of, people are even developing a lorlatinib with less CNS side effects. So we believe that's not an ALK effect. We believe that's related to NTRK, and people are developing sort of lorlatinib-like molecules without NTRK. So yeah, I think it's really exciting. The other one is, the idea is there anything you can look at, and you've done a lot of this work with this up front, that you can say these are higher risk people, and do we need to study those people who are going to have less benefit than average as a separate group? Mm-hmm. Do you want to just sort of explain a little bit about that?
Right. So not only in ALK-positive lung cancer, but in other subsets of non-small cell lung cancer where patients receive targeted therapy, we know that it's not uniform. The responses are not uniform. There's variability in terms of the depth of response initially, as long as the duration of response. So some patients are able to stay on a TKI for several years, whereas others may be on a TKI for 2 months, even, you know, as short as 2 months before they see progression.
Yeah.
And so why is that? If everyone has ALK-positive lung cancer, why does that variability exist? That tells us that the tumors are so much more complex, right, than just looking at the target. And there has been some work looking into this, looking at TP53 mutations and their impact on survival, looking at ALK fusion variants and how they may impact treatment outcomes. But I think really what we're seeing is that we're just at the tip of the iceberg in terms of trying to break down the underlying mechanisms behind that heterogeneity in the outcome.
Fantastic. So Linnea, would you like to take us home with both your vision for the future, what you'd want, and also what you would say to somebody who has just been diagnosed with ALK and is as terrified as you were when you were first diagnosed?
Right. Well, my vision for the future is I'd love to see a 4th generation ALK inhibitor.
Okay.
I also would love to see us get to a place where potentially we understand how these drugs work in individuals well enough to pulse treatment instead of having it all the time, because that would help address some of the side effects. As far as someone newly diagnosed, I would tell them that there are so many options now for treatment compared to where I have stood. Frankly, each time I've started a new ALK inhibitor, just because of timing, it has been with the knowledge that there was no next ALK inhibitor.
Yeah.
So how wonderful that there is this virtual portfolio now. And then the other thing I would say is, and this is not so much to patients, but back to what you were saying about progression-free survival, that means squat to me. I'm only concerned with overall survival. And there are a lot of people in the community who focus on being cured, or they want to be NED, no evidence of disease. And I just tell people, I'm MDY, not dead yet, because I've never been NED in this whole time. I have always had cancer, and yet I have managed to live. So I think that's a way we need to view this too, that as much as we'd all like to eradicate disease, there is at times a way to live with it.
That's fantastic. What a great note to end on.